My name is Julian Foote. I am a consultant orthopaedic surgeon. I'm trained in trauma and elective orthopaedics. My subspecialty interest is hip replacements and knee replacements, or surgery to the lower limb arthroplasty. Patients normally come to see me because of either pain either in their hip or in their knee. I see a range of patients from young patients to old. Tends to be typically an older patient who may be concerned they might have arthritis of either the hip or the knee, and that probably makes up most of my workload. Typically my workload tends to do with patients who have degenerative change or osteoarthritis of either their hip joint or their knee joint. For all groups of patients with hip pains, it can be a range of soft tissue problems to more degenerative process. For knees, again, from soft tissue problems to arthritis. Most patients present with two main things, I would say, are pain and loss of function. Most people are struggling with pain with their daily activities. They may not be able to walk as far as they want, or they're struggling with activities, or unable to exercise like they used to. And that goes, I guess, with loss of function as well. They can't do what they want to do. Often a lot of patients will have obviously tried to manage their conditions for some time, taking painkillers or various remedies. But when they feel they've exhausted conservative measures, often they find their way to see me. So say a patient came to see me with hip pain. So I'd see them here at the Bath Clinic. I'd introduce myself. I would hopefully make them get comfortable. I think above all I'm a good listener, so I'll listen to the problems. And we start off with taking a history. There's an opportunity to hear about what's happened. I'll hopefully ask them direct questions about the symptoms and that they might be having and how intrusive they are. Following the history, often I'll examine the patient and do that gently as I can. Obviously don't want to hurt the patient. And then often they'll be followed by some investigations, typically an X-ray, and then following all that, then we'll put it all together and I'll sort of make a diagnosis. Once you've got a diagnosis, then you can plan treatment, whether it's non-operative treatment or operative treatment. If someone's got cerebral arthritis, they might be talking about something like a hip replacement. The majority of my workload is to do with hip replacements, and that can be from young people to old people. I offer a range of different types of hip replacements, from fully uncemented to hybrid hip replacements, where you have one of the components cemented in, the other one isn't cemented in, to fully cemented components. Having listed someone for an operation, the next thing that will happen is they'll be seen in pre-assessment clinic when they almost have like what's called a medical MOT, make sure they're fit for surgery, make sure they can tolerate the operation, make sure that all the issues have been addressed medically to make sure they're fit to proceed. I typically, before they come to pre-assessment, the time when they're clinic appointment with me, I'll simply go through a consent so they're fully aware of all the risks and benefits of the operation. On the day of the next time we probably meet will be on the day of surgery. On that day, the patient will come in early. They'll get to see the anaesthetist. I'll see them as well. We'll put a mark on the skin. We'll go through any concerns or questions they may have the operation. Most patients will stay in hospital about 2-3 days, something like that. And then they'll be seen by physiotherapists. I'll see the patients every day. They'll see the anaesthetist as well post-operatively, seen by physiotherapists. The medical team will keep an eye as well. We do blood tests, X-rays, and often then once if the wound's healing up well and the X-rays look good, then patients will typically go home, like I said, about the 2-3 day mark. I think things have definitely evolved over time, right? Choni was the man who invented the hip replacement, and certainly things haven't changed a huge amount of what it actually looks like, but certainly the techniques have improved over time, and I use sort of modern techniques. I'm fellowship trained and have sort of trained in all that sort of aspects of hip surgery, and so in all modern techniques, but things have definitely changed. I think one thing I certainly do now, which is I think certainly help in modern times, is template patients. So we'll get at the time when they come in, I'll get an X-ray of your hip with a marker, so that I've got a special computer program to ensure that everything's optimized so exactly where this component should be, to sort of help with planning. The bearing surfaces have certainly improved over time, and I use modern bearing surfaces as well as the implants as well. So everything is tried and tested and reliable. So like I said, the implants I use have got a good track record. I think one of the biggest papers out there was published a few years ago from the Lancet, says that most hip replacements now, you can quote patients around a 70-75% survival at 25 years. So I chose a lower limb arthroplasty, that's hip replacement, knee replacements mainly, because out of all subspecialties, it really is, you can make such a difference to someone. You know, they come in with terrible pain, you know, replace an arthritic hip or an arthritic knee joint, and it can be truly miraculous. I mean, you really, from someone in pain who can barely walk, you can change someone's life, and it is incredibly rewarding, not only for the patient, they're grateful, but on a personal level as well. To feel I can give someone a new lease of life is amazing. It is, yeah, I'm very lucky, I have to say.